Good evening, everybody, and welcome to another exciting Wu University event. I am your host and founder of Wu University, Dr. Stephanie Wu. Thank you so much to Glaukos for supporting this event with an unrestricted educational grant. So it's my pleasure to introduce our speaker, Dr. Justin Schweitzer. I've known Justin for a couple years now. I've attended a lot of his events. He is definitely an expert in many things, specifically glaucoma. So it's really, really exciting to have him today. Dr. Schweitzer specializes in advanced glaucoma, refractive surgical clinical care, and anterior segment pathology at Vance Thompson Vision. He graduated from Pacific University College of Optometry in Forest Grove, Oregon. And in 2012, he pursued his dream to focus on glaucoma, advanced anterior segment pathology, and he joined Vance Thompson Vision in South Dakota, which is where he lives now. He also has research interest in minimally invasive glaucoma surgery and biomechanical properties of the cornea as it relates to glaucoma. So clearly he is a very well-versed and amazing educator in all things glaucoma, but especially for Migs, which is what we're going to be talking about tonight. So it is my pleasure to introduce Dr. Justin Schweitzer.
Thanks so much, Stephanie. Man, this educational stuff that you're putting on with university is just amazing. I've heard so many good things. Had a chance to jump on one or two, and really an honor to be here with you. So thanks so much for having me and let me spend the next 50 minutes or so with everyone and talking about some things that I'm passionate about, which is definitely minimally invasive glaucoma procedures, and not something that I'm obviously doing, but something that I'm involved in because of the practice that I'm in. And really my role in my practice is I'm an optometrist. Obviously I work alongside a glaucoma trained, specialist. And really what he's tasked me to do is he's asked me to be, in charge of the clinic, to manage patients, to kind of be an avenue for our referring doctors, our referring optometrists when glaucoma patients need surgical procedures. And so, I don't really have any of my own patients. What I'm really doing on a daily basis is preparing patients for surgery, getting them ready for a lot of these Migs procedures, helping to make the decision on, what Migs procedure is best for their type of glaucoma. And we're going to talk about that tonight. Handle some post-operative issues that may creep up after minimally invasive glaucoma procedures, and really keep him in the operating room for as much as possible. He doesn't want to be in the clinic. He wants to be up doing what he's skilled at, which is doing surgery. And that leaves me to do, the clinical care, which I think tonight, and I'm hopeful tonight, that a lot of you, after you spend this next 50 minutes with me, are going to feel really comfortable with minimally invasive glaucoma procedures, understand some of the post-operative nuances around them, and really feel like you can make some recommendations to your patients, or at least handle some of those post-operative issues that you may run into with minimally invasive glaucoma procedures. Some financial disclosures that I need to disclose. I work with a lot of the minimally invasive glaucoma procedure companies out there. And so these are my disclosures that I want to put out there. And then we're going to be talking about mastering the management of Migs. Really, as I mentioned, we're going to talk about, what do you manage post-operatively? What are the different Migs procedures out there? How do you utilize those in clinical practice? How do you talk about your patients? And we're going to be focused a lot on the surgical piece here, but I don't want this to sound like I'm bashing other treatment options for glaucoma. I'm very thankful for glaucoma medications every single day. I utilize them all. I'm thankful for glaucoma drug delivery, which we now have in the market. But Migs really has served a really nice role in our practice. And you'll see that as we kind of get into some different scenarios here. So as optometrists, why should we really care about Migs? We're not putting these things in people's eyes. And really why we should care is because it really does make our patients' lives better. That's the most important thing. But the second piece is, in my opinion, it makes our lives better as well as the doctor managing glaucoma on a daily basis, because we're able to reduce the burden of medication for our patients. We're able to hopefully control their glaucoma easier and at a higher level. And that's really where Migs can come into play. And there's a variety of other things we look at. Compliance, a huge issue in the glaucoma space. When we think about compliance, we know from different studies that our patients don't use their glaucoma medications the way that they should. One study on the left there, you look at the prostaglandin analogs right here in the middle. By 6 months, less than 50% using their medications at all. not just being non-compliant, just not using them at all. And that's a famous Nordstrom study that we've all probably heard of. On the right, a glaucoma monitoring study, a medication, a prostaglandin given to these patients for free, told those patients, hey, you're going to be monitored. We're going to watch you use your medication. And 75% of them or 45% of them use the dose less than 75% of the time. So even though they were told it's free, even though they were told they were going to be monitored, they still couldn't do it correctly. And so we got to figure out ways to at least reduce the burden of medications, getting patients from 3 to 2, 2 to 1, or 1 to 0. And that's really where Migs can serve a really nice purpose. We also know that our patients that have side effects from glaucoma medications will progress more. And why is that? Probably because they're not using their drops correctly. When their eyes are irritated, sore, they're not going to use them, and that leads to progression. This study looking at patients with side effects in the red, patients without side effects in the blue, and you can see the visual field progression over time. The ones not having side effects still progressing because glaucoma is a progressive disease, but not progressing as fast as what our patients with side effects will have. And so again, reducing that burden, trying to reduce side effects equals more control of patients' glaucoma. This was a study that I did with a colleague and friend of mine, Dr. Whitney Hauser, and we looked at patients that were undergoing a minimally invasive glaucoma procedure and patients that had ocular surface disease as well. And I don't think this study is going to blow anyone's mind, but it never been looked at. No one had ever looked at what is the impact of Migs on the ocular surface and really the quality of life for our patients. And what we did in this study is we just had patients fill out an ocular surface disease index. You can see on the right there, preoperatively, 47 patients. Their percentage, their OSDI or average OSDI was 40.1, which is in the severe level. This was before surgery. These patients all were on medications. They underwent a minimally invasive glaucoma procedure. And 3 months later, what we had them do is take that OSDI again. And you can see the significant drop in that OSDI index down to 17.5, almost normal, mild, but almost normal. And then some other things came out of this study as well, a 49% longer tear breakup time, less corneal and conjunctival staining, and a trend towards less hyperemia as well. And so we know that ocular surface disease comes from glaucoma medications. We have ways to at least consider reducing some of that ocular surface disease with Migs. And then I'd like you to think about this term as well as I go through the different procedures. Interventional glaucoma. It used to be that we would add a medication when our patient was getting worse, and then we would add a second one, and then we would add a third one. And after that, you'd send the patient out for a tube shunt or a trabeculectomy or filtering procedure, which is more risky than a lot of the Migs procedures. When we think about interventional glaucoma, it's been this shift, this thought process of using procedures that are safer. We can intervene at an earlier stage in the disease. We can intervene in the mild stage, in the moderate stage, which we're not going to do with a tube shunt or a trabeculectomy. And so the patient on the left, for example, with a visually significant cataract and mild glaucoma, makes a ton of sense to have the cataract taken out and do a Migs procedure. But what about the patients on the right? Someone on top there that's pseudophakic, for example, and they're progressing. Do we have options? We do. We have Migs procedures that I'll talk about. What about the patient in the middle there? Patient of mine that comes in every time I see him complaining of, boy, my eye's red. You can pick out which eye's red and which one's not from the multiple medications on. He's not progressing. He's not getting worse. Is it right to do a Migs procedure in a patient like that? And I would argue it probably is. His quality of life is being affected. His eyes are being affected. He's suffering. Although his glaucoma is not getting worse, can we intervene and reduce that burden of medication for him? And then the patient on the bottom, she can't get her drops in. She's not putting them in correctly. That's a patient that likely over time is going to progress because either she's going to stop using the medication or it's going to continue to not get in the eye. So keep that terminology, interventional glaucoma, in mind as we kind of go through the different procedures here in a little bit. So I think of Migs kind of like a bridge. We have our conservative therapies, which would be, for example, our topical glaucoma medications. We have SLT. We have glaucoma drug delivery on the market. And then there was this gap. We didn't have something to kind of fill that space to those more aggressive therapies, like our filtering procedures, our trabeculectomies, our tube shunts, where it comes with a lot of risk, a lot of concern. You can get hypotony with that. You can get infections. The failure rates can increase with that. Now we have this kind of middle ground Migs, which, yes, it's not going to get pressure as low as a tube shunt, as low as a trabeculectomy, but they're still very efficacious, as you'll see here in a little bit when we get into the data shortly. So this is the definition of minimally invasive glaucoma procedures or minimally invasive glaucoma surgery. These are procedures that typically take an ab internal approach. They're minimally traumatic to the eye. They are at least modestly effective. I mentioned maybe not as effective as a tube shunt or a trab, but they do a good job at lowering pressure. They have a high safety profile, and these patients do recover fairly rapidly. And really, when we talk about all these today, you're going to see that. You're going to see the data, and I'll talk about some of the tidbits with that. So I just am always curious. So poll question popping up here. I want to know currently in the audience that's out there tonight, when you refer a patient to a glaucoma specialist or a glaucoma surgeon or someone doing Migs, are you working with surgeons that are doing just one type of Migs? Are you working with surgeons that are doing multiple types? Or you're working with surgeons that really aren't doing Migs procedures at all? And I'll admit it right now, a strong believer that you really should be working with surgeons that are doing multiple Migs procedures. And really the reason being is not every Migs procedure fits every type of glaucoma. Not every Migs procedure fits every type of patient. I'm going to kind of talk through that here in a little bit. So we'll go ahead and look at the results here. Yeah, so great. So 67% of you already working with surgeons that are doing multiple Migs types of procedures, about 19% with one type, and then some not working with surgeons at this point in time. After this talk, I'm hoping you say, I'm finding one that's doing Migs procedures because the benefit is there for your patients. So collaborative care in glaucoma. I'm also a big believer in collaborative care. I talked about it earlier that really I don't have patients in my practice. I'm working with other optometrists that refer patients to us. When we're done doing the surgery and we get them through a postoperative period that the optometrist would like us to, they're going back to the optometrist for continued care. And I think that's the best care possible for our patients. I don't need my schedule bogged down by doing a ton of glaucoma follow-ups when the optometrist that's right next door to me can do an amazing job of handling that. And so collaborative care to me is work with surgeons that have the same mindset that you do. Work with surgeons that want to be in the operating room, that are doing multiple Migs procedures, that want to get the patient back to you, to your comfort level, so that you can manage these patients, because it's a win-win-win situation. That's a win for the patient. It's a win for you as the optometrist, and it's a win for the ophthalmologist as well. It's going to provide better care for our patients. Cataract surgery alone, probably the most common glaucoma surgery that's performed today. And I always get this question, is cataract surgery alone enough? Can it lower pressure enough? And in certain situations, yes, it can. But this was an interesting study published in 2019 in the American Journal of Ophthalmology. And they looked at patients that were undergoing cataract surgery. And after cataract surgery, after they followed them for an average of about 5.5 years up to 6.5 years, was there still visual field progression occurring in this primary open angle glaucoma patient population? And what was interesting about this study is it did exactly what we'd expect. Cataract surgery lowered intraocular pressure. When the cataract came out, pressure went down. But what did not happen is progression didn't stop. We still saw mean deviation rate increase consistently. We still saw the VFI rate increase consistently. We saw the pattern standard deviation increase as well. And so it really begs the question, can we add something that's safe, effective to the cataract procedure to lower pressure more, to try to really slow down progression even more? And that's really where Migs comes in, because a lot of the different Migs procedures we'll talk about tonight don't really add any risk to the cataract procedure. They're very similar. The safety profile doesn't get worse because a Migs procedure is being done, except for maybe when we're talking filtering procedures, maybe a subconjunctival stent, there's a bit more risk there. And I'll talk about that here tonight as well. So real quickly, just a quick case here. And this is really just to set the table of an ideal Migs type of patient. So this was a 69-year-old Caucasian female that came in to see me for a cataract evaluation. And, they wanted an opinion on the glaucoma, but had really kind of already diagnosed the patient. And the patient said that, she wasn't taking her drops every day. She was having burning, irritated eyes and blurry vision at the time as well. And you could kind of see her ocular history there. She was on a medication, latanoprost once a day, had a family history of that. And her highest pressures were about 25. Her medical history there over on the right. When we look at the ocular exam, visual acuity about 20/25 minus 2 in the right, 20/30 in the left, and brightness acuity testing down to about 2400. Really, the slit lamp exam looked pretty good for everything. And I'll show you an image of her lens here in a second, and her pressure being 18 to 19 on that prostaglandin analog. So down from a Tmax pressure of 25 to 18 to 19. Let's say that's a pretty decent drop. We know from the early manifest glaucoma trial in those early diagnosed patients, we want 25% or more to really slow down the progression of glaucoma. If we get 30%, we're thrilled. And that's what we would expect from our prostaglandin. So fairly well controlled. Biggest issue is she's not seeing right. And then thin corneas, a high corneal hysteresis, which is an indicator of less risk of progression. And then you can see the optic nerve PET evaluation there as well at 0.6 in both eyes. Gonioscopy, the other thing I wanted to comment on, obviously very important. We can't diagnose without doing gonioscopy. And then more importantly now, if you're getting involved with doing Migs procedures or getting involved in co-managing these things, we have to be able to visualize the angle to be able to, let's say, for example, look at a stent that could be plugged with a tuftavirus or could have, a PAS or peripheral anterior syncytia that's plugging it. So we've got to be good with our gonio skills as more and more of these kind of enter the market. Here's the slit lamp exam. So you can see this patient had a visually significant cataract. And then when we look at the OCT, right eye, just borderline thinning, right at that edge, right? Average retinal nerve fiber layer thickness of 78. We look at this curve up here, the Tisnet curve, and it's really hovering around that lower edge. We're starting to get a little bit concerned, but we look over there at the left eye, and we definitely have some retinal nerve fiber layer thinning, temporal inferior, nasal superior. Thankfully, when we looked at this patient's visual field, there may be a small defect in that left eye that could be corresponding. I'm a big fan of repeating visual fields, but sometimes in my situation, I have to make a decision. The patient's coming in to see me. I'm looking at old visual fields that, again, the optometrist has been focused on doing for an extended period of time. And so I make decisions a lot of time off records from other places and then the visual field that I obtained that particular day. And then you can see the right eye showing no visual field defects at all. So that for me is a patient that is absolutely perfect for a minimally invasive glaucoma procedure. We're going to make that patient happy because number one, we're going to remove their cataract. They're going to see better. What's the other piece to it? We're going to probably be able to get them off that medication by doing one of the minimally invasive procedures that we're going to talk about. And if we can't get them off the medication, we're at least going to have that added benefit of that Migs procedure to control their intraocular pressure as well. All right, so let's dive into the different minimally invasive procedures. And this is just kind of an overview, and we're going to touch on all of this here in a little bit. But on the left side are all the Schlemm's canal procedures. You have stents, you have dilating procedures, you have cutting procedures, ablative procedures. None of those procedures on the left bypass episclerovenous pressure, which is that kind of backstop pressure that doesn't allow the eye to go hypotenuse. So you don't have to worry about hypotony with any of those procedures on the left. When we get into the suprachoroidal and the subconjunctival areas, that's where we have to worry a little bit more about hypotony. Now, we don't have any suprachoroidal devices on the market at this point in time. We have one subconjunctival stent, which is called the Zen stent, that's on the market. And that's a more of a filtering procedure. And we'll talk about that in a little bit. Those patients can go hypotenuse. And so there's a little bit more risk with that. And then on the right, I added the cilioablative procedures. The nice thing about an endocyclophotocoagulation is it's addressing aqueous production. If you ablate the ciliary processes, you slow down the amount of aqueous flow. That can be paired with one of those procedures on the far left, one of those Schlemm's canal procedures, which addresses outflow. And so you can kind of attack the intraocular pressure in a couple different ways, via outflow and by production of aqueous as well. So I'm going to start by just kind of going through a couple different stent options here. And we're going to start with ideal patient types for trabecular microbypass stents and also Schlemm's canal micro stents. And to me, the most ideal patients for these two types of devices is a patient with the visually significant cataract and mild to moderate glaucoma. In those types of patients, it makes a ton of sense to go ahead and stent the meshwork. And I'll talk about that here in a little bit. So what are our different procedures? Well, the first one is a trabecular microbypass stent. Istent Inject W would be the one that you've heard about the most lately. You can see the video down there in the inferior right corner there. And so really what's happened is the cataract's being taken out. And then the next step is 2 stents are being placed. And the surgeon injects one, moves about 3 clock hours, and you can see another stent being placed as well. On label, this is done in conjunction with cataract surgery. You can see how it looks on gonio. with the upper image there. And they look like really tiny little punctal plugs that allow aqueous outflow through the trabecular meshwork into Schlemm's canal. Where do these work best? Well, we studied this at our center, and we actually looked at the first generation stents. So this doesn't include stents where there were, this doesn't include patients that received 2 stents. But what I wanted to point out in our particular study is an N of about 440. So a lot of patients in this particular study, these patients all underwent cataract surgery plus a stent, and then they were also on medications. What we found out was patients that had that higher baseline pressure, you can see it on the right, 24 or above, they got the most IOP lowering, 12.3 millimeters of mercury lowering just by taking a cataract out and placing a stent. You could see when the pressure was lower, we didn't get as much IOP lowering in that situation. And so for me in clinical practice, it's very easy for me to look a patient in the eye that has a visually significant cataract, that has mild to moderate glaucoma, to say, and if their pressure is above 24 above, I'm pretty confident telling them, hey, we can get pretty significant IOP lowering by doing this particular procedure. Remember, that was just 1 stent. There are studies now showing that 2 lowers pressure more than 1. And really that's what's being done on the market today is the 2 stent approach, or what I just showed you there a second ago. So really this data can be applied clinically, which I've really enjoyed. And then this study is interesting in the fact that they actually gave us some visual field data. In this particular study, these patients received 2 stents again. These patients all had open angle glaucoma. They were all phakic. And so this is not on label. Okay. These patients were all phakic on 1 medication. And you can see that their baseline pressure was about 19.5. They washed them off the medication. It went up to about 24.4. And through 4 years at this point in time, their pressure is at about 13.2, with the majority of these patients not back on a medication. So well north of 80% not taking a medication at this point in time. But more telling about this study is the stability of their visual fields over 4 years. You can see mean deviation. You can see pattern standard deviation. On the left is at baseline, and on the right is where they're at 4 years later. So really no change in pattern standard deviation and really minimal change in the mean deviation. So holding things steady through a 4-year period. Another device that works very well is a Schlemm canal micro stent. This is a scaffolding device. To be on label, it's done in conjunction with cataract surgery. What happens here is the device is placed through the trabecular meshwork into Schlemm's canal. It takes up about 3 clock hours. It allows aqueous to flow in through the trabecular meshwork into Schlemm's canal, but it also dilates the canal as well a bit because it's a scaffolding procedure. And you can see that stent there on the left. Again, done in conjunction with cataract surgery. And again, you want to look at this with gonioscopy afterwards. And I'll touch on that here in a little bit. When we look at the main clinical trial for this, it's the Horizon trial. And really what I want to point out at the 4-year update is at 48 months, that 4 years, 65% of these patients were medication free. Patients at 48 months unmedicated, their pressures were 16.7. Their baseline medicated pressure in this particular study was about 17.8, 17.9. So medicated, their pressure was higher than it was at 48 months unmedicated. And you can see the medications in the bottom there, 52%, 47%, 2 to 4 medications. And so very impressive data with this particular stent. And again, outperforming cataract surgery alone. You look at the 5-year updated data, 66% of patients at 5 years at this point in time are remaining medication free, with 61% not needing further intervention with this particular stent. So I see just a couple of questions popping up. I'm just going to make sure I can answer those. How do we know that the pressure drop is not due in part to the cataract surgery and subsequent opening of the anterior chamber? 100% cataract surgery plays a role in lowering pressure. But if you look at all the cataract surgery studies, it's only lowering pressure from about 2 to 5 millimeters of mercury. And the other reason we know that the stents are working is when you look at the Horizon data right in front of you right now, it outperforms it. And in the istent studies as well, trabecular microbypass studies, cataract surgery plus a stent outperforms cataract surgery alone. And so, yes, cataract surgery is playing a role. It's lowering intraocular pressure, but adding one of these minimally invasive procedures is lowering pressure more than just cataract surgery alone. And it's just proven in the FDA clinical trials, not only in the Horizon trial, but also in the studies that were done with the trabecular microbypass stents or the the istent studies. So this video is fascinating to me. This is some work being done by Alex Wong, and it's fascinating because he's injecting aqueous. So it's this aqueous angiography. And what you're seeing in the video on the left is before he placed 2 stents. And so what you're seeing are the aqueous collector channels. You can see in that left video there in the inferior portion, there is some flow of aqueous into those collector channels. When you look at the rest of the eye, though, there's not a lot of flow happening. There's not a lot of flow of aqueous into those collector channels. When you look after stenting on the right with this video, you can see all the extra flow that's happening, all the extra aqueous moving into those collector channels, which is just interesting because to me, this is the holy grail of placing Migs procedures. If this can be done in a non-invasive way where surgeons can actually target where there's trouble with flow into the aqueous collector channels, they can say, hey, I'm not going to place all these nasally because most Migs procedures are done in that nasal quadrant. Maybe a patient needs it in the temporal quadrant. Maybe they need it in the inferior nasal or superior temporal. And so they'll be able to target where they're going to place these Migs procedures and just make it more effective. And so I always am just so interested when I see this video because it's just fascinating how no flow versus flow by really just placing 2 small stents in the angle there. Question just came up, how often do stents, clog? Great question. I'm going to hold on that question because in a little bit, when we get into postoperative issues, I have the percentages for you from the different studies that are out there. So a question about AMD exacerbated by cataract surgery and adaptive Migs procedures. There is some data out there about cataract surgery studies on that. No studies that I'm aware of looking at AMD exacerbated by cataract surgery plus a Migs procedure. So the only thing I would say is I probably would look at the cataract surgery data and assume whatever that's showing that it would be fairly equal. I don't have percentages. I just know there are some papers out there that have looked at cataract surgery and the exacerbation of AMD. But the fact is, when we're treating something like glaucoma, if it makes sense to do a safe procedure, it makes sense to bridge versus a filtering procedure. I'm going to do it mainly because it's what's best for the patient. All right. So moving on, ideal patient candidate. So I talked about stenting a minute ago, done in conjunction with cataract surgery, done, that's its on-label usage. And just to kind of give you a philosophy of mine, I'm a believer in stenting first. We talked about 2 different types of stents there. And the reason why I'm a believer in that is it preserves the trabecular meshwork for other procedures like the 2 we're going to talk about next. And these 2 procedures are both great procedures. We utilize them in our practice all the time. But the issue is these procedures are goniotomies or removal of the trabecular meshwork. And when you remove the trabecular meshwork, there's no way to place a stent. And so I always feel like if we go to one of these procedures first, I'm removing tools from my surgeon's toolbox that he can do later down the road. And so we, in our philosophy and our thought is let's stent first, as long as it's on label, done in conjunction with cataract surgery. And then we reserve these because these can be done in conjunction with cataract surgery, but these procedures also can be done in our pseudophakic patient population, and insurance coverage is good. So these have a little wider array of options for us and can be utilized a little bit farther down the road if maybe we didn't get what we needed with a stenting procedure. And so a mild to moderate glaucoma patient that's phakic or pseudophakic, these 2 procedures I'm going to talk about next are good options. And so the first one is an excisional goniotomy. Really what this is doing, it's removing or excising about 3 clock hours of the trabecular meshwork. It's allowing aqueous to flow right into Schlemm's canal to lower intraocular pressure. Again, can be done in conjunction with cataract surgery or as a standalone procedure. You can see that image on the left on gonioscopy, that opening of the trabecular meshwork, or it's gone now at that point in time. You're looking right into Schlemm's canal. And that's important postoperatively because you want to look on gonio to make sure that that doesn't seal up over time. You want to make sure that it's patent and it's still working a year down the road, 2 years down the road, so on and so forth. When we look in the data on this, a little less data than what we see with the Schlemm's canal micro stents, trabecular microbypass stents, but still good data showing us that it's very effective and it still does a good job of lowering intraocular pressure. The interesting thing about these incisional goniotomies is it seems to work well in patients that even have lower baseline pressures. And that's really what you're seeing here. Although the N is small at only 26, you can see based on IOP less than or equal to 16.5 right down here. 84% of patients on one or fewer medications from baseline, although only a 20% reduction at 15%, harder to get a 20% reduction when we're talking about pressures that low. You see here with higher pressures above 16 and a half, 100% of the patients, although the N low, got a greater than 20% reduction in IOP. And again, nearly half the patients on one or fewer medications. So definitely effective procedure that can lower pressure in our patients as well. So a question coming up, the ideal patient has a visually significant cataract and a higher IOP. Is this a T-max or untreated, or is this with topical treatment? It's a great question, and it really varies from market to market. In our particular market, the patient that comes in with a visually significant cataract, a higher IOP, they have to be medicated in order to get a Migs procedure covered. Now that can vary, and so I would talk to your surgeons. In some markets, you can actually do a Migs procedure on an untreated situation where maybe they have a cataract, a high IOP, and you want a Migs procedure, you can do that. In our particular study, all those patients that you saw that had pressures above 24, that got that 12 millimeter of mercury lowering, those are all medicated patients. Every one of those patients was at least on a medication. They were on average, about 1.4 medications, to answer your question. And so, it varies again from market to market. And I would just find that out if they have to be medicated or not medicated in order to do that visually significant cataract plus a Migs procedure. This is just another 12-month study looking at standalone excisional goniotomy. So we're still talking about that particular procedure. A patient here based with about pressures around 21. These patients did not have a visually significant cataract. So these patients were pseudophakic or phakic. And you can see that pressure drop of about 25% in this situation. And you can see the loss or decrease in IOP lowering medications, again, with this excisional goniotomy. So another question popping up, and these are great questions, so thank you. What are some causes of goniotomy failure that I've seen clinically? Really, it comes down to, the angle, and unfortunately, the angle is kind of crowded, right? So at a more open angle, these procedures are going to be more successful. That's why when I'm doing gonioscopy, I really want to make sure that it's not a narrow angle. I want to make sure I at least see scleral spur. A lot of times I want to see the ciliary body, and I'm more comfortable that way because narrow angles to me are the ones that have failed most often for me. The other thing is patients that have a lot of inflammation. So say it's a patient with previous iritis or uveitis. You can get failure with this because the angle can seal up. You can get adhesions in the angle. And so it's not going to work as well. So I'm very careful in patients that have a history of a lot of inflammation. I've seen failures there as well. And then finally, you can get PAS. You can get peripheral anterior syncytia that just kind of occlude or go over the top of the goniotomy. It can happen with the stents as well. And I'll touch on those percentages here in a second. And so those would be kind of the three things that I've seen clinically where it's failed. And the good thing is what we've done a lot of times, if it was successful the first time, my surgeon will go back in and actually repeat that procedure as well. Question coming up, are there any Migs procedures FDA approved for chronic angle closure, crowded angles? Really, no. I mean, when we talk about the stents, those should be open angle situations. The goniotomies, you could. The problem is, again, the surgeon has to have visualization. They have to be able to get in there to be able to remove it. And so really a warning or precaution, I would say maybe even close to a contraindication, is someone that has a crowded or narrow angle, especially in an angle closure situation. A Migs procedure is not going to be ideal for those particular patients. Great questions. So this is just a quick video of what the Cook dual blade looks like. You can see he penetrates the trabecular meshwork, and now is just going to kind of slowly strip the angle, and then he'll go in there with the forceps and actually remove that excised trabecular meshwork so it's not hanging out inside the eye. And it's about 3 clock hours, as I mentioned earlier. Another procedure, again, can be done in conjunction with cataract surgery or just standalone. This is an ab interno trabeculotomy plus viscocanalostomy. Say that about 3 times fast and your tongue will be twisted. What's happening here is they're running a catheter in through the trabecular meshwork into Schlemm's canal. This can be done 180 degrees or 360. As they're retracting it, they're injecting viscoelastic. And then they'll go back in the eye after the viscoelastic has been placed. And now you're going to see they're going to kind of remove or strip the trabecular meshwork, which is opening up the canal. And so you get all the adhesions that have built up in the canal being broken up by the visco portion of it. The visco is being injected, it's breaking everything up. And then you're opening up the canal by removing the trabecular meshwork. So really addressing three different resistance points. Number one, removal of the trabecular meshwork. Number two, opening up Schlemm's canal. And number three, gaining access to the aqueous collector channels. And so again, done in conjunction with cataract surgery or standalone. This was a study done by Dr. Steve Sarkeesian showing very effective IOP lowering at 12 months. And then a more recent study that just came out, which is actually interesting to me. You have group one, group two. They broke these patients up into a higher pressure situation, which is the triangle group there. That was group one. And what we would expect in these patients, they're all pseudophakic. Their pressure dropped. They went down. More interesting to me is actually group two, which is the pseudophakic group that has a lower baseline pressure. You can see pressures of about only 15.1. And pressure only went down slightly. And we'd say, well, boy, is that a win? We only got, a half a millimeter of mercury drop in IOP. That's where the interventional piece comes in, the interventional mindset. It was a win because in that group two patient base, the majority of these patients were off their medications. Even though they got a half millimeter mercury drop in IOP or 1 millimeter drop in IOP, they got off the medication they were on. And so the quality of life for that patient, their pressure still being controlled, they're staying stabilized. They don't have the burden of taking that medication. And so I think that group two is very telling in regards to that. Another great question just popped up. When do you stop glaucoma medications after a Migs procedure? Great question. I'm going to come to that. I'm going to cruise through this next section because I want to spend the last 15 minutes or so talking about postoperative considerations, talking about stopping glaucoma medications. I mentioned ECP earlier. I just bring this up. Keep this in mind as pairing it with a lot of the Migs procedures we just talked about because it's decreasing aqueous production. You're attacking this in multiple ways. Migs procedure being the outflow pathway with a stent or a goniotomy, ECP decreasing aqueous production, so endocyclophotocoagulation. All right, so I'm going to skip over the case just because I want to leave us a little bit of time. But when we think about an ideal patient candidate in this next group, this is a different category than the group that we talked about earlier, a different category than our stents, than our goniotomy, than our Omni procedure. And the reason why it is this is more advanced glaucoma. These are patients that you've maybe exhausted some Migs procedures with, or you've exhausted topical glaucoma medications, and they're at the point where you feel like, boy, they need a filtering procedure. They need a tube shunt. They need a trabeculectomy. This would be an option. You could think about a subconjunctival stent, which is called the Zen stent, in more of your refractory patient population. This can be done in conjunction with cataract surgery. This can be done in pseudophakic patients. It really doesn't matter, but keep in mind it's more for those advanced glaucoma patients. This isn't for your mild to moderate types of glaucoma patients. So the way that it works, a lot of times it's being ab external right now, but when it was originally released, it was done ab internal. And you can see up here in this top image, they make a clear corneal incision. They come across the anterior chamber. They penetrate at the level of the trabecular meshwork. They then go all the way almost through the conjunctiva, but they leave it there because what you get is you get this kind of conjunctival bleb. You have about 2 millimeters of that stent sitting underneath that conjunctival bleb, 3 millimeters of it in this intrascleral space, and about 2 millimeters of it in the anterior chamber. And so you do have to deal with bleb complications. You do have to worry about bleb infections. You do have to worry about hypotony as well because it's bypassing episclerovenous pressure. And so it's not uncommon at day one for these patients to have pressures of 3 or 4. And so hypotony is the concern with this. It behaves kind of like a little noodle. It's actually hydrophilic. And so once it's implanted and aqueous starts to go through the actual tube, it actually swells a little bit, kind of elevates a little bit, and kind of plugs that opening that was created when it was placed inside the eye. So a question came up too, do patients need to be pseudophakic for ECP? Yeah, you would very likely create a cataract if the patient was phakic, but no problem if they're pseudophakic. So yes, the majority of patients with ECP, or all of them, are really pseudophakic in nature. concern with going into the eye with a fake patient is a cataract would be created. So thanks for the question. I did not clarify that. So in their FDA clinical trial with this particular stent, the mean deviation on the visual fields was -15 or above. So these patients had significant bad glaucoma. I mentioned that earlier. You can see what their medicated pressure was, right around 25.1 at baseline. At baseline, these patients were on 3.5 glaucoma medications. And then you look at 12 months, really effective IOP lowering went from 25 down to 15.9. And then glaucoma medications going from 3.5 down to 1.7. I think the biggest issue that you're going to run into this when you manage these patients post-operatively is, number one, you are going to have patients that have some hypotony. What you'll find out quickly, though, is a lot of times there's no intervention needed. And I'll touch on that in a little bit when we get into post-operative complications. How do we manage hypotony after a Zen? Most of the time, there's really nothing you need to do except monitor the patient. The other thing you're going to find out with these patients is bleb needling needs to happen. We mentioned earlier that there's this bleb. There's a bleb that forms from this procedure. And unfortunately, with a bleb comes fibrosis. And when it fibroses down, the pressure can go up. The stent doesn't work as well. And so what happens is a little needle is used. Surgeon comes in, goes into the bleb, and will break up all that fibrotic material around the end of the stent. And you can imagine it's not really the highlight of a patient's day when you say, hey, we got to go into the eye. We got to break up this bleb. Break up this fibrotic material. It's a little bit uncomfortable for them, and they're typically a little bit bummed about it. And you can see in the FDA clinical trial, well over 30% had that occur. There's been a shift in how this procedure is being done. A lot of times, instead of doing the ab internal approach, you're going to see a video here in a second of an ab external approach. And the reason that's being done is better visualization for the surgeon and less likely for that stent to be caught up in subtenon space or getting that fibrotic material building up as quickly. So this is the ab external approach, and this is done differently by different surgeons. You can see in this particular case, they're just taking the needle and going right through the conjunctiva. They'll create an angle here, penetrate right through the sclera, and then place the stent. Some surgeons will actually take the conjunctiva down, take the sclera down, place it, and then kind of sew back over the top of it. But it's gone to this more ab external approach to kind of prevent, hopefully, some of that bleb needling. Comment popped in, what is the effectiveness of a Zen compared to an Ahmed valve? So no head-to-head that I'm aware of, but what I can tell you is Zen stent, typically where pressure is going to settle at is around that 12 to 13 mark or so. In my opinion, a tube and a trab are going to be more effective at lowering intraocular pressure. You're going to get lower pressures with that. But in my opinion, if you look at the safety profile, tubes and trabs, they're going to fail at a much higher rate. There's going to be more risk with them. You got to worry about hypotony at higher rates. You got to worry about infections at higher rates. And when you look at the tube versus trab study, 50% of trabs failing at about 5 years, about 30 or so percent of tubes failing at about 5 years. This to me is kind of a bridge before we go to a tube and trab, taking a little safer approach, but still being fairly aggressive. And that's really been my experience with this particular stent. And a lot of times where we're doing this is we're doing it in the inferior nasal quadrant. So we're preserving that whole superior area so that if we need to come back and do a tube someday or come back and do a trab, we're not going to have that Zen stent in that particular area. All right, so poll question number 3. I'm just interested, how many of you are co-managing patients that have undergone Migs procedures? I would ask this question, and I have asked it 6 or 7 years ago, and the percentages were low and totally understandable. I've just been really interested and excited for our profession because every time I ask this question now at meetings or when I'm giving one of these lectures, the percent just keeps going up higher and higher. And it just shows to me that, we are embracing these types of procedures. We're managing glaucoma. We're communicating with our surgeons that are doing this. And so I'd love to see, those percentages continue to go up higher and higher. And I love to see a lot of times people say, docs say, no, I'm not doing it, but I'm interested. So we can go ahead and bring those percentages up right now. Yeah, great. So, over a quarter already co-managing, being involved in managing minimally invasive glaucoma procedures. well over 50% not doing it, but interested. And I love that as well. And then, that lower percent, I know there's still some of you out there, it's just not for you. My goal tonight was to hopefully change some of your minds, get that 15% even lower. And I know we're not quite there yet, but I always have an open email too. So I'll put my email at the end of this presentation. Anyone wants to reach out to me at any point, anytime, please feel free to do that. So let's spend the last 10 minutes or so talking about postoperative considerations with Migs, because a couple of questions popped up and they were great questions. And one of the questions that came up is, well, when do you stop glaucoma medications? And there's really no cookbook recipe for this, but I'm going to give you my philosophy and what's worked. And I'll give you some of what my colleagues have done too, and what they've educated me on as well. And the first thing you need to look at is look at the severity of the glaucoma. I'm much more aggressive at stopping glaucoma medications in a patient that is ocular hypertensive or has mild glaucoma than I would be in a patient that has moderate glaucoma or severe glaucoma. And I educate differently as well. Patients that are, on the mild end, I'll say, hey, there's a good chance I'm going to be able to get you off of one of your medications because your glaucoma is so mild, and we have procedures that are going to be able to help with that. I'm much more guarded in my education in patients that have moderate to severe glaucoma, where I say, hey, we're much less likely to get you off of one of your medications, but this will serve as really another medication in addition to the ones you're on. So the severity really matters to me. When do you pull them off? When we think about it at day one, the only time I'll ever take medications off at day one is with the subconjunctival stent or the Zen stent, because almost always those patients are going to be hypotenuse. And so I would definitely remove all medications on day one with the subconjunctival stent. With all the other devices that we talked about, the ones that don't bypass episcleral venous pressure, I will leave them on their medication for sure up to week one. I have a target pressure in my mind for every single patient that's going under one of these procedures. And I'm comfortable with pulling them off a medication one at a time. I only do one medication at a time at a week. Now, some of my colleagues, and I have no problem with this, like to wait till a month. And I think that's very reasonable. You wait till 1 month because then they're off their steroid, they're off their postoperative medications. You maybe have that intraocular pressure well controlled. They're at the target pressure, then peel off that medication. But again, I urge you, I would only peel one off at a time. And then each visit that you see them, if they're at their target pressure, you can peel another medication off. If they spike or they go up, you have the opportunity to just add something back, because you're going to be seeing them at 1 day, 1 month, 3 months, and you'll be monitoring them closely. And so that's really my rule of thumb, is I would start peeling one medication off either at 1 week or 1 month when you're comfortable with that, and only do one at a time. And as long as they're at their target pressure. If they're not at the target pressure, then you got to leave them on that medication. PAS, there was some question about the clogging up of the stents. When does that happen? We talked a little bit about goniotomy, and I listed 3 different scenarios where we run into a situation where that goniotomy may not work. Another situation are stents. Stents can get plugged, and you can see in the pivotal trial for trabecular microbypass stents, it was about 1.8% of patients at 24 months. You can see in the Horizon trial at about 4 years, it was about 13% of the stents had PAS to those stents. Now, how do you fix it? The surgeon doesn't have to go inside the eye and remove the stent per se. A lot of times what they can do is they can use a YAG laser and just remove that little bit of PAS that may be plugging the end of these stents. And this is why gonioscopy is so important, and why I preach about it, because I've saved a few patients from having to undergo more surgery. I've saved some patients from having to undergo, more surgery by just taking a look at the stents. And my rule of thumb is you should look at the stents, or you should look at the goniotomy 1 time in the first 3 months. So do gonioscopy 1 time in the first 3 months, and then look at those stents or the goniotomy or whatever procedure they've had done every year thereafter, just to make sure that's still patent, to make sure that it's still working as well. So question coming up, recommended follow-up in my practice. So this particular comment is, our practice to see patients at 1 week, 1 month, yet rarely we have seen pressure spikes at 3 months visits on Migs that worked very well initially. So if I'm reading it correctly, you have seen pressure spikes at 3 months on Migs that worked very well initially. Completely agree. I've also seen that. And that's why I do think seeing them at 1 week, 1 month, and 3 months is important. And again, base it off the severity of the glaucoma. If it's a patient that has moderate or severe glaucoma, you may bring them back at 1 week, 1 month, 2 months, and 3 months to catch that spike, because that optic nerve head is much more susceptible than what, an optic nerve head for someone that has mild glaucoma or ocular hypertensive. And so I will bring patients back at times, maybe at 2 months, rather than wait into that 3-month visit because of that spike in the susceptibility of the optic nerve head. But rule of thumb traditionally has been, 1 day, 1 week, 1 month, and 3 months, but based off the level of the severity as well. Hyphema. So with all the different Migs procedures, you're going to see hyphema. This is common. You're going to run into it for sure. And don't be alarmed by that. Educate patients on the front end when they're undergoing a Migs procedure. There's very likely going to be some blood inside the eye. And if you see a hyphema like this in this image here, it's just a wait and watch approach. It's very likely going to go away in about a week. I don't do anything differently. I don't change anything. Everything stays the same. It's just more of education. If you see one like this, which is quite common, it looks kind of like an anterior chamber reaction. It's really red blood cells floating around. Same thing. It's just education. The patient's going to notice the vision's a bit cloudy. And so I let them know that that can happen. It's kind of like a snow globe. In South Dakota, we get a lot of snow. So that's what I equate it to. That's how I educate my patients. You think of those snow globes, you shake that up, all those flakes floating around. That's what happened inside the eye. And sometimes what will happen is the patient will say, boy, I saw really good, in the morning when I woke up, but as soon as I stood up, I couldn't see anymore. And that's because the blood had kind of settled down when they're sleeping. They stand up and now that blood's floating around. Again, 1 week, it really dissipates in almost all scenarios. At times, it can stick around a little bit longer. If you see a hyphema like this, though, this is one I would send back to the surgeon. That really needs to be washed out, taken out of the eye. We can't have that in the eye. It can cause pressure problems, obviously visual issues. And so the first 2 images, wait and watch. That particular one, send them back to see them. IOP spikes. I throw this video on here because I think probably many of you are already doing this, but I think we're all very capable of lowering pressure by burping the wound or doing an anterior chamber decompression. And in our glaucoma patients, and this would be done at day 1, that has a really elevated intraocular pressure, it's something to definitely consider. Our patients that have glaucoma are more susceptible to damage. And so throwing some glaucoma medications, may lower their pressure, but it's nice to be doing it in a quick fashion. And so my rule of thumb is I do this on day 1, give the patient a drop of proparacaine. They'll like you a lot better. I then will not stain the incision. I used to when I couldn't visualize it. I feel comfortable enough where I don't stain it now. If you're doing your first few, you may want to. And then I use a sterile punctal dilator. And I don't go inside the eye. There's no reason to go inside the eye. You can do it right on the outside edge of the wound. And you want to burp the small wound. Don't burp the large wound. Usually there's 2 wounds that the surgeon creates. Burp the small wound when you're doing this. The patient will already be on antibiotic because they just had surgery. And then I will make sure that they either stay on their glaucoma medication. If they're not on any, I send them home with one. And then I see them back 24 to 48 hours later, just to make sure that that pressure didn't jump up or spike on me again. But it's a very quick, effective way to get IOP lowering in patients that may have an IOP spike. And then ocular hypotony. You're going to run into this with that subconjunctival stent, with that Zen particular stent. And in this situation, I can tell you a lot of times there's nothing you need to do. What I would recommend you do is, number 1, stop all their glaucoma medications if they're on anything. Number 2, dilate their pupil. Make sure you take a look in the back of the eye. Look for any choroidal folds, look for any choroidal effusion. You want to make sure that the eye isn't kind of wrinkling up on itself, because if it is, and the choroid or the retina looks like it's going to touch, you're going to want to send that back to the surgeon to reinflate the eye. And then look at the anterior chamber. Make sure the iris isn't bowing forward, or that the cornea isn't bowing backwards, where there could be some iris corneal touch. That would be a situation as well that you're going to want to send that back to the surgeon. But the majority of the time, you're not going to have to do that, because the Zen stent, although it lowers pressure significantly, you don't run into a ton of hypotony with that. And you saw that in FDA clinical trial as well. So comment question, glaucoma med of choice when I'm burping a wound. I would say anything but a prostaglandin. And that's not a knock on prostaglandins. When you burp a wound, you want something that's going to act fast, and prostaglandins just act slower. And so anything but a prostaglandin, CAI, fixed combination agent, any of those beta blockers, something that's going to act quickly. And so that would be the only thing. Dilation, a contraindication for any of these procedures. No, you can dilate your patients if they've had stents, if they've had goniotomy, if they've had any of the procedures we talked about. No problem dilating your patient, doing your comprehensive annual eye exams on these. So no concerns there at all. Great question on the burp. How long does the lowering last? It really depends. That's why I see my patients back in 24 to 48 hours, because I have had times where the patient's pressure will spike. And when it spikes, you want to catch that. So 24 to 40 hours just to make sure that it's lowering. My instrument of choice is a sterile punctal dilator. That's what I use. Another great question. And then how am I measuring pressure post Migs? For us, we use, a CATS tonometer. It's a newer tonometer tip. We use Goldman as well. And then we actually use an instrument called the Ocular Response Analyzer, where we're measuring corneal hysteresis as well as IOP-CC. So we kind of use a variety of things to measure intraocular pressure as well. All right. So really, in conclusion, glaucoma, I talked about, it's both medical and surgical. We still need topical glaucoma medications, but surgery is a thing. And the key is collaboration. I think we have to talk to our surgeons. We want to be comfortable with managing these things. You can be comfortable with managing things. It's a win-win-win situation, as I mentioned earlier. We have to balance effectiveness and safety. We don't want to do a glaucoma procedure that's going to put the eye at more risk than what the disease itself is going to do. We don't want to do a trabeculectomy in a patient that has mild glaucoma. That's a patient that should get glaucoma medication, SLT, maybe a Migs procedure. So balance that effectiveness and safety. And then finally, don't forget that term, interventional glaucoma. I think it's a big term. It's something that patients don't always have to be progressing. We have to think about quality of life issues as well. So there's my email address. Stephanie, thanks so much for having me. Really had a great time, and hopefully I'm ending right at 8:30. So we'll get everyone out of here, and feel free if there's any questions. I'm happy to take a few and stick around. So I just appreciate everyone taking some time tonight. I know it's never easy, middle of the week. You're busy in clinic to spend time here. So thank you.
Wow, that was an incredible lecture. I feel like now I know nothing about glaucoma after I've watched your presentation. You just know so much more than I do. And
you're selling yourself short. I know that much. I know that.
No, that was amazing. And I think, like, when we were in school, this wasn't even an option yet. So this is something that if you graduated, 10 years or more than that, then this is relatively new information. It's not something that we really learned about in school. So it's really interesting to learn about these new procedures and new innovations in glaucoma. And it's so exciting to just be able to offer something to patients that have glaucoma that's not just eye drops and it's not just trabeculectomies anymore. I mean, this is such an exciting advancement. Migs have really helped so many patients, and I'm just really excited to see what the future holds. I mean, some of the information that we've seen, some of the clinical trials that you presented, and some of the amazing things that are coming out in the future are really awesome. So yeah.
Your point, Stephanie. I mean, you're right. It's in its infancy still. Like the things we're talking about tonight, a year or two from now could change. It's only been around for 10 to 12 years. 2012 really was kind of the first Migs procedure. And so it's in its infancy. We're all learning together. I'm learning too every day. So.
Wow. Well, that's amazing. Justin, you're so knowledgeable in this topic. I know that a lot of people had requested you to give this exact lecture, and I'm sure anybody listening in knows why. You're just
thank you.
An excellent speaker, and just what amazing information. So thank you so much.